everyone. Welcome to Breaking the Chain with Caitlin, a digital story vodcast. Each episode, we explore unique roles of various healthcare workers relating to infection prevention and control practices. I'm your host, Caitlin Cosgrove, and today we'll be talking about working with vulnerable clients, specifically the pediatric population. Now it's time to welcome our guest, Vikky, who is a staff emergency RN and clinical instructor. Hi, Vikky. Welcome to the show.
Hi, Caitlin. Thanks for having me.
Would you be able to share with the viewers a little more about what you do?
Yeah, sure. So I work in a urban pediatric emergency department. I've been in emergency department for the past almost 4 years now, and previously I worked 4 years in a general medicine floor, but still with the pediatric population. And I also currently work as a clinical instructor with nursing students, both in year 1 and year 2, in both the clinical setting and also in the lab.
Wow, thank you for sharing. So, working in a pediatric emergency department, how do you maintain infection prevention and control practices?
So there's definitely a lot of challenges in the pediatric population because it does get quite messy sometimes. And also, being in emerge, it's quite fast paced, but, we always consistently have to maintain, the 4 moments of hand hygiene is easy, just in and out of the room, any kind of body fluids, hand hygiene. There's like alcohol-based hand rub stations like outside every patient room, inside every patient room as you enter and leave. And so there's really almost no excuse not to be adhering to your principles of hand hygiene in the 4 moments. It's also especially important to be mindful when you do come in contact with bodily fluids. In the peds population, there's so many different kinds of bodily fluids, whether it's emesis, secretions from a trach, snot from the nose, a runny nose, even handling of breast milk. Those are all, points of care where you need to stop and perform hand hygiene, whether you're donning and doffing gloves. And then speaking of gloves, it's also important just to remember when you need to change your gloves in between different procedures. It's so easy sometimes people put on gloves and they think that, that's going to keep them safe from everything, but no, that's not the case. So for example, during like your typical neonatal sepsis workup, we would need to collect a urine sample with an in and out catheterization, and then obtain blood cultures and other blood work. And then while you're doing that, you should be obtaining your IV access. And then we also typically also want a nasopharyngeal swab to rule out any kind of RSV, the flu, and right now, of course, COVID. And so between all those 3 points of procedures, you actually need to stop and change your gloves, especially with the in and out catheterization. That should be a sterile procedure. Being mindful of that. And also, that has to do with, you could potentially be contaminated with urine or fecal matter. So you have to, take off your sterile gloves once you're done the procedure, perform your hand hygiene. That one, I would say ideally, not just the alcohol-based hand rub, but your soap and water, because, you never know if you might be contaminated, like you soiled your hands physically, but not visibly. And you still need to, and then change your gloves, along with blood work, because you don't want that contamination with your blood culture, especially. And I think all of these steps require emerge nurses, any nurse, to be very mindful of what is sterile and what is aseptic technique as well, on top of your hand hygiene. What is your appropriate PPE in this scenario as well? And so the other, so that's kind of, those are kind of like the main things I would say we would maintain IPAC practices in emerge.
Wow, that's so many different points of consideration that I didn't even think of. And which patients are most vulnerable to healthcare acquired infections?
So I would say the most vulnerable populations that we do see, definitely are neonates under the age of 10 to 12 weeks. They're especially vulnerable. Their immune system is not really developed yet. They're still receiving antibodies from their mothers if they're breastfed. And then also oncology patients, especially those who are in treatments, who are on immunosuppressant medication. And then of course there are just also your immunocompromised patients. and then patients with complex care needs who, may or may not be on a trach, have a tracheostomy tube, and also on a ventilator on top of having a trach, or they have a PICC line with multiple lumens. Lots of potential for risk for infection there with those really vulnerable access lines into that goes right into their heart, more or less. So I would say those are kind of our more vulnerable populations.
Mm. And do you have a short story about any of the in any situation where you worked with someone who was vulnerable to an HAI?
So definitely, like I mentioned, your immunocompromised patients, your oncology patients, and neonates, and the patients who are complex care, especially those with trachs, those are kind of are vulnerable to HAIs. If we suspect that the patient is, vulnerable, we typically try not to keep them in the waiting room and emerge. We would put them in a room right away so that they are not sitting out in the waiting room with other potentially highly contagious patients. We want to keep them apart. It's also interesting because the minute that we identify that they are a more vulnerable population, we also triage them differently. They are definitely placed on a more higher acuity. So they're likely to be definitely have to be seen quicker. And by seen, I mean having a primary provider, like a physician emerge and the nurse. There's actually time, kind of, what's the word I want to use? There's a targeted time that these patients must be seen so that they're, so that they are assessed in a timely manner and provided treatment right away. So those are kind of some of the things we do. We also, what do I want to say? I guess also the other things with these vulnerable population, I think that's important to consider with HAIs, is just, again, keeping them safe from other patients, hand hygiene, and then as clinicians wearing the appropriate PPE, taking them on and off. I think, anecdotally, before COVID, we weren't always the best with putting our gown and gloves when we see a patient. And now that COVID's here, it's changed the culture so significantly. Like it's crazy. And you have to have, face shield to protect your eyes, because we found out that, HAIs and any transmissible infectious agents like COVID could be transmitted through the eyes. So
Wow. Thank you so much for sharing. And how do you adapt infection prevention and control teaching strategies for pediatric patients and their care providers and families?
So there's kind of two components to that. One's the peds piece, and then one's the family piece. With the pediatric, with any pediatric or any patient you have, really, you really have to consistently apply developmental assessment and, understanding what is their level of understanding and using appropriate techniques so that you can try to keep everyone as safe as possible. I think sometimes with peds, you kind of have to adapt your own mind frame too. You can't expect, a 2-year-old or 3-year-old to understand infection prevention control. So sometimes the strategy isn't so much how you're going to teach them, but how much you have to kind of almost manipulate your own techniques and strategies to keep everyone safe as much as possible. That might mean, if they don't understand that they have to do hand hygiene, then you're going to have to follow up with cleaning staff or yourself to make sure you thoroughly clean, I don't know, a toy after, or a table with appropriate cleaning agents. I think that, like right now with, for example, with COVID, with the masks, it is very challenging to get younger children to wear masks. I think the rule, unless it's changed, typically we try to have any patient over the age of 6 to be maintaining a mask on at all times while they're in the hospital. But I've also seen children as young as 2 and 3 understand that, they have to wear a mask. So it really depends on their understanding and developmental stages. Sometimes it's just the verbal encouragements. For example, when I walk in a patient's room, if I see that a child doesn't have a mask on their face, I might just, kind of walk up to them in a non-confrontational way, just casually stoop down to their level and in a friendly voice, like, say, let me just help you fix your mask so we can keep you safe. And most of the time, they're more than okay with that. You literally have to be hands-on and just be mindful. Like I'm fully donned with gloves,
Mhm.
gown, mask, so I have no problem, fixing their mask for them. And sometimes just that, friendly little gesture of helping them fix their mask in a caring way. I haven't really met any resistance in that matter. And sometimes you have to explain it to them a little bit too. You want to keep them safe, but
Mhm.
you also want to keep other people safe. Um, and sometimes you might even throw in other people just to give them an idea, so there's this bug going on and there's a lot of other kids around. So by wearing this mask, you're keeping them safe as well.
Mhm.
So that kind of just like a broad explanation usually does the trick. And obviously if they're older, you can definitely explain more in depth as to why. And most of the time, once they're older, you don't really need to explain. They know what's going on right now, right? So but other times you just kind of use it as like a role modeling thing, tell them all the big kids are doing it.
Oh.
It's doing this cool thing. Other times I point out, like, so the masks where I'm working have colorful dinosaurs on it. So I point out how cool that is. I don't often do this because I know PPE is kind of, limited sometimes, but I've done something where like I've put a mask on a child's teddy just so that it seems more normal for them. Like, your teddy's wearing a mask. So it's not as scary and weird if their teddy's wearing a mask too. So it kind of helps a bit. And then with the family piece, it definitely requires sometimes a little more understanding and trying to recognize their strengths, if applicable, as to like how you can get them to follow IPAC principles. There's definitely sometimes resistance, and you have to kind of explain, this is kind of the norm now, and you have to keep the mask on, keep everyone's and themselves safe, really. Um, if there's sometimes getting this understanding means that there's like a language barrier, so you definitely want to use language line or interpreter. And then on the flip side of working in an urbanized like pediatric emergency department, is that there are parents who are quite accustomed to being in and out of the hospital. And in that way, they sometimes have their own way of like maybe cleaning a trach or something or suctioning. And sometimes they might need a refresher and just kind of doing a gentle gentle reminder way. Maybe they need more practice, and you kind of just do that with them. Or sometimes we'll consult. We have like a complex care, kind of like I can't remember what they're called right now, but there's nurses that we can call that will come down to the emergency department, spend more time with them doing teaching. And then on the flip side, there are some parents who are so well versed in IPAC with certain techniques and sterility, like a needle port access. They see it so often that they are the ones watching you like a hawk and making sure you follow every single sterile step.